Welcome to a detailed exploration of chronic inflammatory demyelinating polyneuropathy, or CDP. This complex neurological disorder affects the peripheral nerves, leading to weakness and sensory problems. Join us as we delve into the causes, symptoms, diagnosis, and treatment of this challenging condition. The exact cause of CDP remains a mystery, but it's believed to be an autoimmune disorder. This means the body's immune system mistakenly attacks the myelin sheath, the protective covering around nerve fibers. Genetic predisposition and environmental factors might also play a role, but more research is needed to fully understand the triggers. CIDP's pathophysiology revolves around demyelination, the destruction of the myelin sheath. This disrupts the efficient transmission of nerve signals. The immune system, specifically T cells and B cells, infiltrate the peripheral nerves and trigger inflammation. This inflammation damages the myelin, slowing down or even blocking nerve impulses. Over time, this can lead to axonal damage, the actual nerve fiber itself, causing permanent neurological deficits. CIDP is a relatively rare condition, affecting approximately 1 to 9 people per 100,000. It can occur at any age, but is most common in adults between the ages of 40 and 60. Men are slightly more likely to be affected than women. The incidence appears to be consistent across different geographic regions. The signs and symptoms of CIDP can vary significantly from person to person. Common symptoms include progressive weakness in the arms and legs, often starting in the feet and hands. Numbness, tingling, and pain are also frequent complaints. Reflexes may be reduced or absent. Some individuals experience fatigue, muscle atrophy, and difficulties with balance and coordination. Symptoms usually develop gradually over at least 8 weeks, distinguishing it from Guillain-Barré syndrome, which progresses more rapidly. Diagnosing CDP involves a thorough neurological examination and a combination of tests. Nerve conduction studies are crucial for assessing nerve function and detecting demyelination. Electromyography, or EMG, helps evaluate muscle activity. A lumbar puncture or spinal tap may be performed to analyze cerebrospinal fluid for elevated protein levels. A nerve biopsy can confirm demyelination and inflammation. MRI scans may be used to rule out other conditions. While the classic presentation of CDP is a slowly progressive, symmetrical weakness, there are several recognized subtypes. These include typical CP, distal acquired demyelinating neuropathy ADS, multifocal acquired demyelinating sensory and motor neuropathy METAS-AM, and CIDP associated with specific antibodies like anti-METAS neuropathy. Each subtype can present with slightly different symptoms and may respond differently to treatment. The goal of treatment for CDP is to suppress the immune system and reduce inflammation. First-line treatments often include intravenous immunoglobulin or a VIG plasma exchange, also known as plasmapheresis, and corticosteroids such as prednisone. Immunosuppressant drugs, like azathioprine or cyclosporin, may be used as maintenance therapy to prevent relapses. Physical therapy and occupational therapy are essential for improving strength, mobility, and function. Assistive devices may also be helpful. Unfortunately, there are no known ways to prevent CIDP, as the underlying cause remains unknown. Since it is believed to be an autoimmune disorder, adopting a healthy lifestyle with regular exercise, a balanced diet, and stress management may generally support immune system function, though this has not been specifically linked to preventing CIDP. The prognosis for CIDP varies. With early diagnosis and appropriate treatment, many individuals experience significant improvement or remission. However, some people may have ongoing symptoms or relapses. Early treatment is crucial in preventing permanent nerve damage. Research continues to focus on identifying specific autoantibodies and developing targeted therapies. Newer treatments, like subcutaneous immunoglobulin and complement inhibitors, are showing promise in clinical trials and may offer alternative options for patients who do not respond well to standard therapies.